Okay, I'm Bruce Greenstein. I'm the CEO of Blend Health Insights. We're an advisory firm that consults with large organizations and companies around the country on healthcare, technology, and government. And today,
You used to be an advisor of George Bush, the president?
my previous jobs include running managed care and parts of the healthcare system for George Bush while he was president. And then more recently, I was a cabinet official for Governor Bobby Jindal, and I was the Secretary of Health in Louisiana.
Okay.
And so over the last several years, I've been working with large health systems, technology companies, and insurance companies around certain concepts that we would recognize as accountable care today. And within accountable care, this notion of blended care has been used for a little bit, but not too much. And I'm going to talk a little bit about what blended care is, and then what some of the barriers are, and what some of the benefits are.
Okay. Yeah. So what is blended care?
So
How do you define it?
blended care really is the combination of activities and assets that are enabled by technology outside of the healthcare system itself. So it may be remote monitoring in a person's home after they were discharged from the hospital. Might be connected devices that are used to monitor chronic diseases like diabetes or congestive heart failure. And these techniques are being used for an organization like an insurance company or an accountable care organization to manage risky patients, manage patients that are expensive today or are expected to be expensive in the future. These techniques about blended care are used both for chronic disease, but also being used for mental health and behavioral health issues, because it extends the clinician's reach out into the community.
What's the value of blended care for citizens, for patients?
Yeah, so there's two or three ways to look at it. One is people are safer because they're being monitored, and the risk of going to the emergency room with an issue that needs to be treated, or the anxiety of over having an issue that needs to be treated, is there. Individuals are able to live in their home for a longer period of time rather than moving into an institution. So dignity and independence is maximized. For those that pay for the health care, be it an insurance company or an accountable care organization, the idea is to be able to prevent more costly episodes in the healthcare system. Fewer emergency department visits, fewer hospitalizations, fewer rehospitalizations after a discharge. And so we have all the positive elements that blended care enables. However, it's not being deployed that often around the country.
But could you say you get better quality of care for less money?
Well, we'll say we have better quality of care because we're monitoring patients and we're able to assist where necessary. But in that exchange, nothing costs less. You're actually adding more services to the mix. You only save money if you could avoid a hospitalization or
Is that
avoid.
possible with blended care?
Yes, we've seen many times where the connection between the GP and the patient gets stronger, the care coordination gets stronger, and so when we have people that are either declining or decompensating in their chronic disease or after a hospital admission, we're able to treat them in primary care instead of inside the hospital.
Okay. And you're working on it now very strongly, on the blended care?
Yes, I spent a lot of time working around the concepts of blended care, but there are very few insurance companies that are making programs or funding available for blended care. And so that means that it's difficult to launch a program or sell devices or have clinicians engage in the practice of blended care if there's not a way for the insurance company to compensate either a company that does it or the GP that may coordinate it. So right now we're seeing slow uptake, even though the promise and the demonstration projects have been successful. We're not seeing insurance companies put a lot of money behind it.
So that would be the next step. Convince the insurance companies.
So here's how we do it. We have to be very rigorous in our selection criteria. So only people that really are going to the hospital otherwise, that are really going to the emergency room, people that are discharged from the hospital, and we know that we risk a rehospitalization.